Hello, everybody. Welcome to our webinar today on non-tuberculosis mycobacterial pulmonary disease diagnosis and management, an overview for general practitioners with Dr. Sarah Brode. This webinar is brought to you by the Tuberculosis Committee and the Lung Health Foundation. My name is Jennifer Noble, and I'm a team member here at the Lung Health Foundation. We at the Lung Health Foundation are dedicated to ending gaps in the prevention, diagnosis, and care of lung disease in Canada. We invest in the future by driving groundbreaking research, and we give patients and their families the programs and support they need today. Just to touch on the learning objectives for today's session, at the end of the session, learners will be able to recognize how to diagnose NTM pulmonary disease, describe the clinical factors that should be considered when deciding whether to initiate treatment for NTM pulmonary disease, and describe how to treat Mycobacterium avium pulmonary disease. Just to let you know, there will be a Q&A session after the presentation. I'd like to encourage you all to add your questions in the Q&A section throughout the presentation. We'll read them out later after Sarah's finished. And I'd like to take a moment to introduce our speaker today, Dr. Sarah Brode. Sarah Brode's an assistant professor of medicine at the University of Toronto, the physician lead of the tuberculosis program at West Park Healthcare Centre, and a staff respirologist and a clinician in the non-tuberculosis mycobacteria and TB programs at Toronto Western Hospital within the University Health Network. Her research focuses on epidemiology, treatment, and outcomes of TB and NTM. Sarah, thank you for being here with us today. I'll turn things over to you.
Thanks very much. Thanks, Jennifer. Thanks to the Lung Health Foundation for inviting me to speak and for hosting this webinar. Thanks to everybody who's online. So yeah, I'll get started and I will leave about 10 to 15 minutes for questions at the end. So as mentioned, I'm going to be talking about NTM pulmonary disease, an overview of diagnosis and management. The focus audience for this talk is more generalists, so I understand there's a lot of allied health practitioners on the call, and as well as general practitioners, and hopefully the things I'm going to cover today will be applicable to you guys. So we've already talked about the learning objectives, so let's just get right into it. What are non-tuberculous mycobacteria, or NTM? So NTM are species in the genus Mycobacteria that are not TB complex. They're not germs that cause TB, and not Mycobacterium leprae. So every species of Mycobacteria that's not TB or Mycobacterium leprae are a part of this group of mycobacteria called non-tuberculous mycobacteria, or NTM. There are many, many species of NTM, over 160 species. However, a much smaller proportion cause human disease. Many NTMs never cause human disease, and there's a handful of them that do. NTM are classified, they used to be classified by something called the Runyon's groups, which looked at how quickly they grow in culture and also looked at whether they produce a pigment or not. But that's an old classification. The new classification is generally into two groups, slow growers versus rapid growers. And pretty much rapid growers grow within 7 days, and slow growers take longer to grow. That classification is somewhat helpful because slow growers tend to behave a little more similarly to each other and tend to respond to certain antibiotics, and rapid growers respond similar to each other and respond to certain antibiotics. But within each species, there are some differences in terms of how they present and how they're treated. So you really need to know the species. How does NTM differ from TB? Well, NTM live in the environment, so they live in our water and our soil, whereas TB can only live in an infected host, which is generally a person, although sometimes can be an animal. We think that people get infected with NTM from exposure to the environment. So they breathe in aerosols of NTM from water or soil, and that's how they get infected. Whereas people who get infected with TB get TB from other people. They get it from infected aerosols from other individuals. NTM is not contagious. It's not spread person to person, whereas of course TB is infectious and spreads person to person. In general, NTM are more weakly pathogenic than TB, and certainly there's a spectrum within NTM, but whereas with TB, if you have TB, it's almost always going to progress. It's generally considered to be very pathogenic and almost always requires treatment. With NTM, that's not necessarily the case. Sometimes people can have a fairly indolent infection that doesn't necessarily progress. And often we're all exposed to it. And sometimes we can even be colonized with it, but it doesn't necessarily always cause infection in people. The diagnosis of NTM is more complex than the diagnosis of TB. It requires a combination of microbiologic, clinical, and radiologic criteria, whereas the diagnosis of TB is made when you isolate TB from a specimen from a patient. So the diagnosis of TB can be made with micro alone, doesn't necessarily require clinical and radiologic criteria, although sometimes a clinical diagnosis is made. With NTM, you always have to have all three. So NTM can cause a number of different clinical syndromes. The most common is pulmonary disease, and that occurs in at least 90% of patients, if not more. And the rest of my talk is going to be about NTM pulmonary disease. Much less commonly, but occasionally, NTM can cause infection in people outside of the lungs. In children, it can sometimes cause a superficial lymphadenitis syndrome, so cervical lymphadenopathy. In people who are severely immunocompromised, like people who have HIV with low CD4 counts or iatrogenic immunocompromised from medications, NTMs can cause disseminated disease. So disseminated MAC has been well described in patients with HIV, and rapid growing mycobacteria can also sometimes cause disseminated infections. And then skin and soft tissue infections can occur as well in immunocompetent hosts. Usually that's because of direct inoculation, and actually usually it's nosocomial. So for instance, plastic surgery with contaminated equipment has been associated with skin and soft tissue infections with NTM. Tattoos can introduce NTM. There have been reports of patients getting NTM infections from pedicures. So now we're going to kind of switch gears and focus just on NTM pulmonary disease, which is by far the most common type of NTM infection in humans. And there are two main clinical phenotypes that we see. The first is Fibrocavitaria disease, which presents very similar to TB. So it causes infection usually in the upper lobes of the lung. It's often focal, often causes cavities, and it's usually seen in patients who have emphysema or some underlying lung damage. That can occur in males or females. It's been described more in males, probably because of historical higher rates of smoking and emphysema in males, but certainly can happen in both sexes. The second phenotype, which is the more common phenotype, is nodular bronchiectatic disease or nodular bronchiectasis. That's manifest by mid-lung accentuated bronchiectasis. As you can see in these CT scan slides here, typically the right middle lobe and the lingula are most involved, and the presence of centrilobular or tree and bud type nodules. And this clinical phenotype can happen in patients who are never smokers and have no pre-existing chronic lung condition that we know about and have normal immune systems. And this happens much more commonly in females than in males. What species of NTM cause NTM pulmonary disease? Well, in Ontario, these are the top 5 isolates that we see. So a little bit of a distinction between isolate and disease. This is what we see most commonly in sputum tests that are submitted to Public Health Ontario, but certainly not all of these organisms typically cause disease. By far the most common isolate that we see and the most common type cause of disease is MAC, which is Mycobacterium avium complex, also previously known as MAI. MAC is kind of a group of species that cause a similar type of disease and are treated the same way. Those species include Mycobacterium avium, which is by far the most common, Mycobacterium intracellular, and Mycobacterium chimera. Our second most common isolate is Mycobacterium xenopi, and that's probably also our second most common cause of pulmonary disease. Mycobacterium gordoni is our third most common isolate, but I put it in brackets because it almost never causes disease. We see it commonly in sputum and in other samples. It's almost always a contaminant or a colonizer, very, very rarely causes disease. And then the fourth and fifth are Mycobacterium fortuitum and abscessus, which are rapid growing mycobacteria. And MAC is treated a little different from Mycobacterium xenopi. Those are both slow growers. They're treated similarly. Mycobacterium fortuitum and abscessus, which are rapid growers, are treated very differently from MAC and M. xenopi. In terms of epidemiology, we see that NTM pulmonary disease is increasing worldwide. On the left is data from Ontario, and on the top is annual isolation prevalence, meaning at least one sputum culture positive. And on the bottom line is disease prevalence, meaning 2 or more sputum cultures positive. We can see that both isolation and disease are going up over time. This only goes to 2010, but I can tell you that the trend has continued since 2010. And on the right, that's data from the United States. It's divided by gender, and we can see as well NTM pulmonary disease is increasing there in both males and females. So in terms of diagnosis and treatment, I'm fortunate to give this talk at a good time because there were very recently some clinical practice guidelines that were released. This document was put together by a number of pulmonary and infectious disease societies in the United States and Europe. And this document was published in both Clinical Infectious Diseases and in the European Respiratory Journal just a couple of months ago. And I'm going to be focusing on this document to give you some guidance about diagnosis and treatment. So the diagnosis of NTM, as I mentioned, requires clinical, radiologic, and microbiologic criteria. You have to have all 3 to make a diagnosis of NTM pulmonary disease. In terms of clinical, the patient has to have pulmonary or systemic symptoms. So pulmonary symptoms would be cough, sputum production, coughing up blood or hemoptysis, sometimes chest pain, sometimes shortness of breath. And then systemic symptoms, fevers, chills, night sweats, weight loss. Fatigue is also actually a very, very common symptom that we see in NTM, but of course, very nonspecific. Patients also have to meet the radiologic criteria, and that is essentially they have to have chest imaging that shows cavities, nodules, or bronchiectasis. So on X-ray, if they have cavities or nodules, or if they have a CT that shows bronchiectasis with multiple small nodules and or cavities, that fulfills that criteria. And then they also have to meet microbiologic criteria. So it's generally recommended in order to make a diagnosis, patients have to have at least 2 sputum samples which are positive for the same species, or 1 bronchoscopy sample, so a BAL, bronchoalveolar lavage, culture positive, or a biopsy culture positive, or a sputum culture positive with a biopsy showing evidence of disease, which would typically be granulomatous inflammation. So the reason that it's recommended that at least 2 sputa are culture positive for the same organism in order to make a diagnosis is because these germs are found in our environment, they're in our water, they're in our soil. And if you just isolate it once in sputum, that can sometimes just be a contamination or transient colonization and may not necessarily mean disease. The more we isolate the germ in the sputum, the more likely it is that it's causing disease. And so that's why that criteria is there. So if you make a diagnosis of NTM pulmonary disease, though, it doesn't necessarily mean that the patient needs to be treated. Whereas with TB, diagnosis pretty much equals treatment. With NTM, diagnosis does not necessitate treatment, and the decision to treat is a very complex one, which I'll go into now. So it's a difficult decision, and it's probably the most challenging decision that we face when we treat these patients is if we should treat them or not. The reason it's so difficult is as follows. First of all, the bugs, NTM, are inherently resistant to many antimicrobials. So there's not a lot of antibiotic options in the first place. And we know that treatment, successful treatment, requires prolonged treatment of multiple agents. And multiple drugs for a long duration is often associated with toxicity. So there's a significant risk of toxicity with therapy. And unfortunately, the outcomes are not nearly as good as we would like. So this really distinguishes NTM from TB. With TB, generally, pretty much everybody is cured. And although some patients sometimes have side effects, we're pretty confident that if we give them the right treatment, they're going to get better. With NTM, that's not necessarily the case. In terms of treatment success for MAC, meaning we've cleared the germ from their sputum with treatment, and they've clinically improved. In a systematic review, they found that only 60% of patients who were appropriately treated had a successful outcome. And then in another couple of studies, one from Korea and one from Texas, which looked at patients with the nodular bronchiectatic form of disease and again, these are in expert centers, so centers where they really know how to manage it, they found treatment success in only about 70 to 86% of patients. And then even if we achieve success, so we're able to eradicate the germ from their sputum and the patient improves clinically, unfortunately, there's a very significant risk of recurrence. So one study from Korea showed a 30% recurrence rate at 14 months, and another from Texas showed a 50% recurrence rate at 4 years. That might partly vary depending on where you live and how much mycobacteria are in your environment, but certainly those outcomes are obviously disappointing. We think that the recurrence has to do with the fact that the patient has an underlying predisposition, which puts them at risk of getting NTM pulmonary disease, which may be bronchiectasis, some issues with sputum clearance, COPD, and then obviously they have ongoing environmental exposure to the germ in their environment. So what about natural history? So what if we don't treat patients? What's going to happen to them? So in patients who have the fibrocavitary form of disease, there is not a lot of data on the natural history if we don't treat them, generally because most people treat them. And the reason we do so is that we know that generally fibrocavitary disease progresses if not treated, even sometimes if it is treated, and is associated with significant mortality. So these are a couple of case series that looked at prognostic factors in NTM. Most of them were MAC. And they found that fibrocavitary disease is a consistently poor prognostic factor. Patients with fibrocavitary disease have a higher risk of all-cause mortality and a higher risk of MAC-specific mortality. And that's shown in the Kaplan-Meier curve on the right. Patients without fibrocavitary disease, much higher survival than patients with fibrocavitary disease. So in general, fibrocavitary disease should almost always be treated for these reasons. However, nodular bronchiectasis is a bit of a different story. These are a couple of studies that looked at the natural history of MAC in patients who have the nodular bronchiectatic phenotype or pattern. The first is a prospective cohort that took 150 patients with NTM pulmonary disease who did not require treatment, and they followed them over time. Now, the vast majority of these patients, but not all of them, had the nodular bronchiectatic form. And they found that over about 28 months of follow-up, about a third of patients, 31%, progressed to require treatment. Progression rate was about 20% at 2 years and about 20% at 1 year and 30% at 2 years. The second study was a retrospective cohort of patients with just MAC pulmonary disease. All of these patients had the nodular bronchiectatic phenotype. And this one, they did serial CT scans, so we're able to see what happens to their chest imaging over time. And over 6 years of follow-up, they found that almost all patients, 97%, had progression on CT. So there was some worsening on their CT scans over time. However, about 37%, or about a third, so similar to the previous study, were felt to require treatment. So although everyone had radiographic progression, the clinicians clearly felt that maybe not all of that radiographic progression was significant enough to require treatment, and about a third of patients were treated. Finally, a third very large study, over 1,000 patients with MAC and a different species, Mycobacterium abscessus, who were seen in a specialty clinic in Korea and initially were felt to not require treatment. After about 3.5 years of follow-up, they found that 55% of patients in this cohort did require treatment, so a little more than the previous 2 studies. But among those who didn't require treatment in that follow-up period, which was 459 patients, or 45%, about a third of those patients had spontaneous sputum culture conversion. So they cleared the MAC on their own without therapy. So that also kind of is an important point to consider when you're considering whether to treat. So what do the guidelines say about starting antibiotic treatment? Again, it's important to consider that the natural history is a bit unpredictable in an individual patient. We know that maybe about 30 to 50% of patients in these cohorts will require treatment after a few years of follow-up, but in your individual patient, you may not know if they're going to be one of the ones that progresses or doesn't. Majority of patients progress on imaging, but some patients will spontaneously clear the germ without therapy. So the guidelines asked, should patients with NTM pulmonary disease be treated, or should they be followed for evidence of progression or watchful waiting? And the recommendation was that they suggested initiating treatment rather than watchful waiting, probably because, again, the majority of patients progress. However, especially in the context of smear-positive disease and or cavitation. I would say, from my personal perspective, cavities should be treated, but nodular bronchiectasis, it's a complex decision. They're recommending overall lean towards treatment rather than no treatment, but they also say in the guidelines that this decision should be individualized, taking into consideration a number of factors. And this is also a part of the guidelines. So again, they say this decision should be individualized, and there are a number of factors that should be considered, some of which may favor observation and some of which may favor treatment. So in terms of characteristics that might favor observation, the patient has mild signs and symptoms, if the patient has a high potential for medication side effects, or if they have an organism that's more difficult to treat and less responsive. So for example, Mycobacterium abscessus. Things that would favor treatment would be poor prognostic markers. As I mentioned, cavitation should strongly favor treatment. If they have low BMI, elevated inflammatory markers, those factors have also been associated with a higher risk of progression and a poorer prognosis. A more virulent species that's also more easy to treat. So for example, Mycobacterium kansasi actually behaves very similar to TB. It's quite virulent, it generally almost always progresses, but it's also quite easy to treat. So that would kind of favor treatment. If the patient has immune suppression, you might be more likely to treat, or obviously if they have significant symptoms like severe fatigue or a poor quality of life. This nice review from Kalman et al. Last year broke down the decision to treat into these different groups, which I think is a really helpful way to conceptualize it. So the first group that they discussed is disease severity. So again, if they have fibrocavitary disease, that would be an indication to treat. How severe are their symptoms? Do they have constitutional symptoms? Do they have elevated inflammatory markers or other blood work that suggests poorer prognosis? And then from a microbiologic perspective, how severe is their disease? So if they have smear positive sputum, then that's an indication that they have more severe disease than if they have smear negative sputum. If there has already been evidence of disease progression, that's something to consider. If they develop cavities, if they develop increasing nodules or infiltrates on imaging, that's a reason to consider treatment. Of course, if they have worsening symptoms over time, and if their microbiologic status worsens, so that previously they had smear negative sputum and then they become persistently smear positive. What's the clinical relevance? So again, the NTM species matters. Some species are more pathogenic than others, some are easier to treat than others. Do they have immune suppression? That might favor treatment. Do they need lung transplant? And then host factors. What's their age? If they're very elderly, maybe there are other priorities. Maybe they're at higher risk of side effects. What are their comorbidities? Is that going to make it more challenging to treat them? Do they have a history of drug intolerance? Are there significant drug interactions? What does the patient want to do? How does the patient feel about taking treatment? How do they feel about their symptoms? What are their goals? And what's the goal of treatment, which is generally a discussion between provider and patient. Are we aiming to cure the disease, or are we aiming just to control it? So just another quick slide about species. Species matters, as I mentioned. Not all species are equally pathogenic. This is just a general schema. If we're looking at if you have the organism in your sputum or in your body, how likely is it to progress? MTB complex is extremely pathogenic, almost 100%, and kansasi is pretty close to that. MAC and Mycobacterium xenopi, probably about in the middle. And then M. abscessus, a little less pathogenic. And then, as I mentioned previously, M. gordones, almost never pathogenic. So if we see that in the sputum, we usually don't worry about it at all. It's important, I think, to stress that if the patient is not treated, they need to be followed. And when I give a talk like this to respirologists and infectious disease physicians, I always stress this. Just because they don't need treatment now doesn't mean they're not going to need treatment in the future. As we mentioned, 30 to 50% of patients who don't need treatment now will need treatment in a couple of years. So they have to be followed. They can't be assessed once and discharged. When they're followed, we need to pay attention to their symptoms, pay attention to and address their comorbid respiratory conditions, so treat their bronchiectasis, treat their COPD. And then when I generally recommend when you follow patients serially over time, you're following their symptoms, of course. I follow microbiology to look to see if their sputum becomes smear positive or if they achieve spontaneous culture conversion. I generally follow lung function to see if that's declining over time. And I follow imaging. That's a bit controversial in terms of should you be doing CTs serially or X-rays. I think that's an individual decision, but some imaging probably should be done periodically. And that's because if patients develop cavities or progressive destruction of lung, like progressive significant bronchiectasis, then that's a reason to consider treatment. And I find that with these patients, generally when you develop a relationship with them and they have a good understanding of the goals of treatment, they often know when they need treatment, especially patients who have been previously treated. They have a good understanding of what their symptoms are, and they have a good understanding of when those symptoms need to be addressed. So what about, so who should you refer to and how? So if you are a general practitioner and you have a patient who may have or does have NTM pulmonary disease, then generally it varies a bit depending on where you're at, but generally respirologists and infectious disease physicians both typically can manage NTM pulmonary disease. Some respirologists refer on to ID, but many respirologists can manage this condition. And I would recommend referring if the patient is suspected to have NTM pulmonary disease or if they meet diagnostic criteria for NTM pulmonary disease. However, I would say that if you have a patient who has isolated an NTM in their sputum, maybe just once and has a normal chest imaging and no symptoms, so they don't meet criteria for NTM pulmonary disease, those patients don't all need to be referred. So for instance, if you're collecting some sputum to rule out TB and you get a positive culture for Mycobacterium gordoni, the patient has no symptoms in a normal x-ray, that patient does not need to be referred necessarily because that organism is not pathogenic, they don't meet the disease criteria, and they definitely don't need treatment. So we're going to move on to treatment now. And before we talk about the specific treatment for MAC, which again is the most common NTM that I'm going to be focusing on, I wanted to just talk about non-antibiotic treatments first, because I think that those are really important and sometimes forgotten. So there are a number of different non-antibiotic therapies that we institute or consider in these patients. I've listed them all here. I won't go into all of these in more detail, but physiotherapy or sputum clearance or airway clearance is a very important one. I'll talk about that a little further. Nutrition. So a lot of these patients, especially the ones who have significant pulmonary disease, are underweight and have poor nutritional status. And we know that poor nutrition is a negative prognostic factor. So we generally work really hard at trying to improve these patients' nutrition and trying to get them to gain weight. That may involve referral to a dietitian or the use of supplements. Many of these patients have concomitant asthma or COPD or bronchiectasis. And so bronchodilators or inhaled corticosteroids may be considered, and I'll talk about that a little more later. Environmental interventions, I'll go into it in a little more detail, how to avoid NTM in the environment. These patients have chronic respiratory disease, so the routine recommendations regarding vaccinations would apply to these patients. So for instance, annual influenza vaccination and pneumococcal vaccinations. And then these patients, again, most of them have bronchiectasis or COPD, and so they may have exacerbations that aren't related to their NTM, and those need to be treated. And then sometimes we do actually use surgery to treat patients with NTM pulmonary disease. That's usually done in patients who have localized disease, who also fail antibiotic medical treatment alone. So that's done in certain circumstances. I won't go into that in any more detail today. But I did want to go into chest physiotherapy a little bit because I think that's important. So this is referring specifically to patients who have bronchiectasis, which is the majority of patients with NTM pulmonary disease. And I'm referring to the ERS or European Respiratory Society bronchiectasis guidelines. Sputum clearance or bronchial hygiene or airway clearance, whatever you want to call it, is recommended for patients with bronchiectasis who have chronic productive cough or have difficulty bringing up sputum. And chest physiotherapy has been shown to increase sputum volume, which is actually a good thing because we think it means that they're bringing out their secretions and they're not getting impacted in their lungs. And it has also been shown to reduce the impact of cough on quality of life. So all of my patients with bronchiectasis who were referred to me for NTM, on their first visit, I have them meet with our RT educator, and she goes over sputum clearance teaching with them. That may involve the use of a positive expiratory pressure device like an aerobica or an a cappella device. Those are shown on the top of the slide. And that may also involve certain breathing exercises, certain coughing exercises, and sometimes postural drainage, laying in a particular position to help gravity help you with sputum clearance. For patients who have bronchiectasis that's more severe, and if they have significant impaired exercise capacity, then pulmonary rehabilitation is also recommended and has been shown to improve exercise capacity and quality of life. Now, what about inhalers? So this is not specific to NTM pulmonary disease. This is about bronchiectasis. But there are a lot of lessons, I think, and similarities between the two. So inhaled steroids are actually not recommended in bronchiectasis unless they are indicated for asthma or COPD. And the reason for that is that there's no evidence to support the benefit of inhaled steroids in bronchiectasis, but we do know that inhaled corticosteroids increase the risk of infection. And there is some evidence to show that patients who use inhaled corticosteroids are actually at higher risk of getting NTM. And so for that reason, please avoid prescribing inhaled steroids for patients with bronchiectasis or with NTM pulmonary disease, unless there's an indication in terms of concomitant COPD or asthma. Long-acting bronchodilators are not routinely recommended in bronchiectasis or NTM. However, if your patient has significant breathlessness, then they can be prescribed on an individualized basis. And then nebulized mucoactive agents like hypertonic saline is recommended in patients who have bronchiectasis who are already doing the standard sputum clearance exercises that I talked about on the last slide and still have difficulty expectorating sputum and have poor quality of life. A note on chronic antibiotics. So in patients with bronchiectasis, which most patients with NTM have, we know that if they have frequent exacerbations or frequent flare-ups of the bronchiectasis 3 or more times per year, then in those patients, most guidelines, including the ERS, recommend the use of chronic antibiotics. Now, those antibiotics would be tailored to what the patient grows in their sputum. So if they grow Pseudomonas aeruginosa in their sputum, then they may benefit most from certain inhaled antibiotics. And if they don't grow Pseudomonas, or if they've not benefited from inhaled tobramycin, then chronic macrolides are generally recommended. And certainly chronic macrolides have been shown to reduce exacerbations in patients with bronchiectasis, and they've also been shown to reduce exacerbations in patients with COPD. But please do not prescribe chronic macrolides to patients who have NTM, because macrolides are actually the most important antibiotic to treat NTM, and exposing a patient to chronic macrolide monotherapy significantly increases the risk of the NTM developing resistance to macrolide. So the presence of NTM in a patient with bronchiectasis or COPD is actually a contraindication to using chronic macrolide therapy according to the guidelines. So environmental interventions. We believe that patients who get NTM pulmonary disease get it from the environment. We think that they're inhaling it from aerosolized water or aerosolized soil. And so it makes sense to try to minimize their exposure to aerosolized water or soil. And we do recommend it, but unfortunately there's very little evidence supporting these recommendations. So I just want to give these recommendations with a grain of salt. There's certainly things that I recommend to patients, but I also tell them that the evidence supporting these recommendations is fairly limited. I recommend patients minimize exposure to hot tubs and humidifiers in indoor swimming pools. I recommend patients avoid exposure to carbon filter water pitchers, so that's like a Brode filter, and to ice and water dispensers, because we know that the Brode filters actually do not filter NTM, and NTM tends to grow in these filters and in these water dispensers and actually cause higher levels of NTM in the water in these systems than in just straight tap water. And I also recommend avoiding working with dry soil because drier soil is more likely to aerosolize, and we know there are NTMs in soil. Changing or cleaning shower heads at regular intervals, some people recommend, may be helpful. There are some antimicrobial filters that can be applied to your shower or water tap that claim to filter almost all antimicrobials and have been shown to be helpful in Legionella. They're expensive and you have to change them regularly, so they're not for everyone. There's very little evidence right now that they help in terms of MAC, but some patients who are very keen do this, and we're actually doing a study on this now to see if this results in improvements in patients who have NTM. And then NTM can grow in warm water, but they don't grow as well in very hot water. So increasing the temperature of your hot water tank in your home to over 54 degrees Celsius has been shown to reduce the amount of NTM that's in a home water supply. But of course, you just have to be careful about the water being very hot and scalding small children or elderly people. So that was kind of the non-antibiotic interventions. And now I'm going to move on to, in the next few minutes, the antibiotic treatment for MAC. So again, MAC, pulmonary disease, by far the most common NTM lung infection. And this is how it's treated based on the recent ATS guidelines. So in patients who have the nodular bronchiectatic form of disease, it's recommended that they receive treatment with 3 antibiotics, azithromycin, rifampin, and ethambutol, given 3 days a week, typically Monday, Wednesday, and Friday. For patients who have cavitary disease, which may be the fibrocavitary subtype, or nodular bronchiectatic form if they have significant cavitation, it's recommended that they receive at least 3 drugs, the same 3 as above, but given daily rather than 3 times a week. And then consider the use, additionally, of amikacin IV or streptomycin. And the amikacin can be given thrice weekly. For patients who have refractory disease, which means after 6 months of treatment, they still have positive sputum cultures, then at least 4 antibiotics are recommended. The same 3 as above, plus amikacin. In this circumstance, amikacin liposome inhalation solution, which is a bit of a handful. The short form for that is called ALICE or Arikayce. It's a specific amikacin molecule that's been developed for inhalation and has been studied in MAC. That's actually recommended to be added on in patients who have refractory disease. ALICE is not licensed in Canada, so another alternative would be to use injectable amikacin, either intravenous or nebulized. And patients who have refractory disease should be on the oral antibiotics daily rather than 3 times a week. What about drug sensitivity testing? So we know that in TB and in many other infections, we routinely get drug sensitivity testing, and we use the results of that test to guide antibiotic therapy. In NTM and specifically in MAC, the use of drug susceptibility testing is really unclear. We actually find that in vitro, some germs seem to be resistant, or sorry, some antibiotics seem to be resistant. They have very high minimal inhibitory concentrations, or MIC, so they appear resistant in the test tube on the testing, but then they still work when patients receive them. So the interpretation of drug sensitivity testing in MAC is actually unclear for most drugs. There's only 2 drugs that really should be used in terms of guiding treatment. The first is macrolides. So we know that if patients have resistance to clarithromycin, which is the class drug, represents clarithromycin and azithromycin. So clarithromycin is used in the test tube, but if we see resistance to clarithromycin, we know that they'll also be resistant to azithromycin. And if we do see resistance, we know that macrolides don't work very well in those patients. They have a poor response to standard treatment, and they have poor outcomes, so they're generally treated differently. And the second drug where we do think the drug susceptibility testing matters is amikacin. And I've shown you the cutoffs there. We know that patients who are resistant to amikacin tend not to respond very well to amikacin treatment, whether it's given intravenous or nebulized. So the guidelines recommend that in patients with MAC, drug susceptibility testing be performed in patients who are going to be treated, and treatment be guided by drug susceptibility testing only to macrolides and amikacin. So ignore the drug susceptibility testing for the other drugs, but act on the drug susceptibility testing to macrolides and amikacin. And again, a little bit more about macrolide resistant MAC. Macrolide resistant MAC is kind of like multi-drug resistant TB. It's very difficult to treat and it has a poorer prognosis. And we know that it occurs in patients who receive macrolide monotherapy or certain weak antibiotic combinations. So in an observational study of patients with MAC lung disease, they found that among the patients who got 4 months of macrolide monotherapy, 20% of them developed macrolide resistance, whereas in patients who got standard therapy with macrolide, rifampin, and ethambutol, only 4% of them developed resistance. In another study that had a cohort of patients with macrolide resistance, and they looked back to see what created that resistance, what treatments had these patients received. Macrolide monotherapy was the biggest, likely the biggest contributor, and macrolide fluoroquinolone combination was the second most common exposure. So we know that patients who get macrolide and quinolone without other antibiotics are also at significant risk of macrolide resistance developing, and we recommend against that combination. It appears that ethambutol is the most important drug in protecting against the development of macrolide resistance, so we strive to include ethambutol in the antibiotic regimen for MAC if at all possible. When to stop treatment? So the guidelines ask this question: in patients with macrolide susceptible MAC pulmonary disease, should they be treated for less than 12 months after culture negativity or more than 12 months after culture negativity? And their recommendation is that patients be treated for at least 12 months after culture negativity. So they're treated with the antibiotic regimen that I just described. You serially collect their sputum. If their sputum becomes negative and is persistently negative, that starts the clock, and they get treatment for 12 months after that at minimum. There isn't a lot of evidence supporting this recommendation. This was the recommendation in the old guidelines and it hasn't changed. There's a little bit of evidence. There's this one small study from Japan and there's another small study from Texas that have looked at this, and this kind of shows that patients who got, and in this study, patients who got antibiotic treatment for 15 or more months after culture conversion, among those patients, none of them had a relapse in this in the follow-up period of the study. However, patients who got less than that, some of them did have a relapse. So longer, at least 12 months, maybe even erring on the side of a little longer, seems to prevent the risk of recurrence, at least in the short term. Couple of slides on drug side effects. They're very common in this condition, and I think in terms of strategies to manage it, I think it's important to expect drug intolerance, then you won't be disappointed. So I actually, when I start patients on therapy, I generally start in a staggered fashion. So rather than starting all 3 antibiotics at once, I generally start the azithromycin first, and then I wait 5 to 7 days, and then I have the patient add on the ethambutol, wait another 7 days, and then add on the rifampin. This can help in terms of building up tolerance, I think, but also it's helpful because if they have a significant side effect, then you have a better idea as to which one caused the side effect. Other strategies, so if patients have GI side effects, particularly bloating, loose stools, I encourage the use of probiotics. Some patients find modifying their dietary habits may help. Rifampin is absorbed better on an empty stomach. The other 2 antibiotics you can take with food, and they're probably better tolerated with food. So I generally tell patients to take the azithromycin and ethambutol with food. I tell them to try the rifampin on an empty stomach, but if they can't tolerate it, then I have them take it with a small amount of food. Sometimes moving the time that they take the antibiotics helps. So some patients tolerate the antibiotics much better if they take them at bedtime, maybe because they're sleeping through some of the side effects that might occur a couple of hours after. And then use of antiemetics, antidiarrheals, prokinetics should be considered. It's important to try to strive to get patients to tolerate the standard regimen if at all possible. Most patients will be able to tolerate it if we work with them in terms of these strategies. generally we can get most patients to tolerate. Certainly not all, and sometimes we need to stop one of these antibiotics and use second-line drugs, but we should at least try to see if we can get them to tolerate with some of these interventions. I think I'll skip that in the interest of time. Again, if we really have a patient who can't tolerate one of the first-line drugs, there are some second-line agents that we can use. I've listed them here. Amikacin, I've already mentioned. There's a couple of other drugs, clofazimine. There's some data supporting its use as a substitute. Quinolone's not a lot of data, probably not as well supported as clofazimine. And then linezolid, rarely reused, although it has very little data. And again, it's important when you're treating the patient, you want to strive for a regimen that's going to achieve the goal you're looking for. Are you looking to cure the patient, or are you looking just to suppress the infection? And if you're looking for suppression, you may be able to use a less aggressive regimen than if you're looking for cure. You don't want to suppress the host more than the pathogen, obviously. And we need to avoid regimens that can lead to the development of macrolide resistance. So no macrolide monotherapy, no macrolide quinolone without companion drugs. We think ethambutol is the most important drug to go with the macrolide to prevent macrolide resistance. So if we can't use ethambutol, then clofazimine or amikacin may be the best options as a substitution. I'm going to skip these. So last couple slides, I just wanted to mention a couple of resources that I find helpful. So NTM Info and Research is a patient support group from the United States that produces a very lovely booklet on NTM. That's a patient education booklet that's really helpful. And they also have a really nice website that I tell all my patients to look at. Has some really nice information about bronchiectasis, about the antibiotics, about ways to avoid NTM in the environment. So I'd strongly recommend that. And then the Public Health Ontario group produced a best practices document on NTM a couple of years ago with some nice tips, and that's available at that link. So take-home points. NTM pulmonary disease diagnosis includes clinical, radiologic, and microbiologic criteria. You have to meet all of those criteria to make a diagnosis. But making a diagnosis does not necessitate treatment, and the decision to treat is really complicated. It involves considering disease severity, progression, clinical relevance, and host factors. MAC, the most common NTM, is treated with at least 3 antibiotics for 12 months post-sputum culture conversion. And the regimen is slightly different depending on whether you have cavities or not, and whether you have refractory disease. Okay, so that's the end of the formal presentation. I just wanted to thank you guys for listening. I wanted to thank the Lung Health Foundation for hosting this webinar, and I also wanted to thank my colleague, Dr. Ted Maris, who I work with in the NTM clinic at Toronto Western, and he allowed me to use some of his slides for this talk. I'd be happy to take any questions at this time. Thank you.
Thank you so much, Sarah. That was fantastic. I'm just going to start with our first question here from Wendell Block. For diagnosing disease, are chest x-rays good enough for imaging, or do we need to get a CT scan?
So yeah, chest x-rays are good enough if there is an abnormality on x-rays. So if there is, clearly a cavity, then you can just use chest x-ray, and that's a part of the diagnostic disease criteria. However, if the chest x-ray is normal or there's a very subtle abnormality, then a CT scan is much more helpful because it will better delineate the abnormality and really give you a better idea as to whether the radiographic change is consistent with NTM or not. And I would say from a practical perspective, I almost always get a CT scan just because it allows me to better characterize the abnormality. Of course, we want to make sure that they don't have something else like a lung cancer or something. And it also allows me to follow them a little more closely. So yes, practically you can just use a chest x-ray, although that often a CT scan is helpful as a supplement.
Great. Thanks so much, Sarah, and thank you, Wendell, for your question. I'd just like to encourage anyone at this point, if they do have any further questions, to add them into the Q&A. There's a few more coming in, so we'll get to those. A question from Jennifer McKinnon. Regarding the breakdown of isolates found in Ontario, are there any regional patterns or trends within Ontario, and are they found in one region more than another?
That's a great question. So Mycobacterium avium is by far the most common isolate that we have in Ontario. And we've seen an increase in Mycobacterium avium over the last 5 years. There seemed to be a spike in 2015. And that spike seems to be mostly in the GTA. I don't think we really understand why that has happened, if it has to do with municipal water supplies or water treatment. But my understanding of the data is that M. avium is very, very common in the GTA, more common than in other regions. But M. avium is still the most common NTM throughout the province. Other than that difference, I'm not aware of any other regional differences in Ontario. I don't think it's really been looked at very closely, though.
Great. Thanks, Sarah.
No problem.
Jane McNamee, she says, thank you very much. Great talk. And she also has a question. You mentioned some people clearing the infection. Can you tell us why this might occur and how could we promote this more?
Yeah, that's a great question. I don't think we know why, and how can it happen? I don't think we know that either, but I do think that sputum clearance may be a part of it. So doing the bronchial hygiene or sputum clearance exercises, getting patients to try and clear their mucus every day with an aerobica device or a positive expiratory pressure device, theoretically, I think could potentially increase the likelihood of sputum culture conversion. But there's in the studies that looked at that, there was no association between the different factors that they looked at and the likelihood of achieving sputum culture conversion. So we don't really know why some people do and some people don't. But, you know, just based on kind of logic, I think sputum clearance is probably something that we should be having all patients do.
Great. Thank you, Dr. Brode. Jacqueline Turvey has said, thank you very much. Excellent presentation. So
thank you.
Wonderful. Does anyone else have any other questions? I'm just going to leave this open for a little bit for a few more questions to come in. Or any other thoughts that you may want to share with Dr. Brode? Okay. Okay, so that's it for the question section. Dr. Brode, I really like to thank you for being here with us today, and I'd like to thank everyone on the TB committee and at the Lung Health Foundation for making today possible. Wonderful presentation, thank you so much, and this will be recorded as well if you'd like to watch later or send the link to anyone else within your networks. Thank you all. Have a very wonderful and safe week, and this has really been a great presentation. Thank you again to Dr. Brode for being here today.
Thank you very much. Thanks everyone for attending. Thanks for inviting me. Have a good day.